Great. So hi, everyone. Welcome to the CFAR GHU Clinical Conference. We're very excited today to have Dr. Leah Rubin chat with us about cognition and mental health in the Bartlett Clinic and in patients with HIV. Just going to do a brief intro. So Dr. Rubin is an assistant professor of neurology and epidemiology at the Johns Hopkins University. And she currently is focused on the cognition and mental health of women, especially those aging with HIV. Her work focuses on studying this population during transitional periods, including pregnancy, the postpartum period, and menopausal transition, and has also done a fair amount of work in the Bartlett Clinic with our patient population as well. Her work is interdisciplinary. She works at both the epidemiologic and mechanistic levels, including things like pharmacologic, challenge studies, and neuroimaging. And is involved with multiple cohorts, including the Women's Interagency HIV Study, the MAX cohort, the Bipolar Schizophrenia Network on Intermediate Phenotypes, et cetera. So we're, I know from our standpoint as clinicians in the clinic, we obviously, as our patient population ages, are seeing cognitive issues in our patients, but we also, of course, have many patients who have other mental health and cognitive comorbidities. And so we're very lucky to have such expertise at our fingertips, and we're very lucky to have you present to us today.
Nope. Thank you for inviting me, and it's good to see some of your faces, the rest of you in black boxes, so I'm going to call you all out. But today I thought, given that you're all practicing clinicians in our clinic, I wanted to really speak about integrating cognitive and mental health testing into the HIV medical visit, kind of set the stage, explain, why this matters, and then kind of the tools that we've been using, and then to show you the data that we've collected, and we finally have it published, which is even more exciting. And again, a lot of this is team-based work. Richard Moore, Carrie Althoff. There are a number of people, Joelle Fuchs, who used to be in the clinic, who was on the day-to-day, helping to facilitate. And now Meghana, who's down there, is helping to continue this work. So let's see if I can, I'm not technologically savvy either. All right, so we'll see if I can figure this out. But first, I always like to start by setting the stage as part of, Natasha mentioned. So I not only come from a cognitive neuroscience background, but that epidemiology background tries to give kind of that big picture view. And so as we think about this, I think we all know the 2020, well, actually, they're kind of moving forward goals because we're already in 2021. But the 90-90-90 and aiming for treatment for all, that we're aiming to have 90% of the patients diagnosed, 90% of those on treatment, and 90% of those virally suppressed. And it really comes down to how are we going to make this a reality in all populations? And so this is where I think the CNS complications, and I say that more broadly to encompass both cognition as well as mental health complications, because they're extremely critical, right? If we don't hit that, it's going to hit every single aspect of our treatment cascade if there's any of these CNS complications. And I think, we all know, and this was actually a slide by Glenn Treisman in psychiatry, who wrote a nice paper, and this was still back in 2001, about these dynamic relationships between HIV infection and neuropsychiatric complications. And so, we know even prior to HIV infection, a lot of the folks, and that you see, they come to you, they've been traumatized oftentimes. There's a lot of poverty, mood disorders, cognitive issues, addictions. And that's often, it can be prior to HIV infection, right? Then folks acquire HIV, and then oftentimes you see these same issues again, whether they're pre-existing and they get exacerbated due to inflammation, a lot of the drugs that they're taking, tissue damage, all of these things may play into it. And I also, want to point out of why this is kind of important. And I think we can all agree that, kind of taking this lifespan perspective to each of the patients that we see, because, stress in and of itself, let's put the congenital, acquiring to the side for a second. But as, these individuals are living from early on into adulthood, they're getting multiple hits across the lifespan, whether it's toxin exposure, malnutrition, neglect, abuse, stigma, adverse life events, all of these things can happen. And then HIV kind of comes into play at some point, which is also kind of this additional stressor, all of which could influence brain health, whether it's cognition, anxiety, and depression. Just to give you a few numbers, and this isn't even all of them, but just pulling from a phase 0 clinical trial that we're running and pulling women that are coming into your clinic and doing pretty comprehensive assessments. And the CTQ is Childhood Trauma Questionnaire. And you can see the proportion and 45% reporting childhood sexual abuse. I mean, these are high numbers. We do structural clinical interviews to kind of get at, the diagnoses of lifetime diagnoses. And you can see here, major depressive disorder, 53%, bipolar with non-psychotic features, 15%. So I know, and see these folks who have all sorts of issues, whether it's past, present, or some sort of combination. And I also think it's really important to note that when the patient, and I think you guys know, come to you, whether we talk about mood disorders, anxiety, or substance use disorders, and this is data that's coming from the Women's Interagency HIV study. So this is over 1,000 women living with HIV across the United States. If you take mood disorders, like each of these things separately, I think what you'll notice is that there's a very small sliver that sits on the outskirts, meaning that these individuals who are exhibiting these problems based on diagnostic interviews, there's a very small sliver that only have one of these problems. The majority sits somewhere in between, where it's 2, 3 issues. And so it's really complicated. And then you also have these other factors that I've gotten extremely interested in that can also play into brain health issues, which is, the non-antiretroviral medications, unemployment, cognitive reserve, and all of those other factors that may play into this. And again, as a cognitive neuroscientist, I just need to kind of tell you and just show you a few pictures of the brain for why this matters, for whether we're talking about these mental health issues influencing brain health. First, if you look on the left hand, and this is outside of HIV. So, and these are meta-analyses that, 38 studies that have looked at people with depression. And you can see, areas in the prefrontal cortex where there's deactivation, and you can see in 26 studies of people with post-traumatic stress disorder, where, often you see decreased activation in frontal regions and in limbic regions, amygdala. You see the red hot areas, which are hyperactivation. And so these things which take that outside of HIV. So there's already these issues. So prefrontal cortex, really important for decision-making, executive functioning, all of those aspects. The amygdala, and I call my kids at this as well, is that, when you're young, you're kind of like this. The kids are just overactive amygdalas, right? They're all emotions with absolutely their prefrontal cortex isn't developed. So that's where we see a lot of emotions, coping issues. But when you start in adding in depression, PTSD, you see that there's this overactivation in these limbic regions, and they can't control it with the prefrontal cortex. So now you add in HIV, and this is work that I've done where in the WISE, we've just taken women and just kind of categorize it based on, non-specific stress and anxiety, how unpredictable, overloaded that individuals perceive their lives to be. And if you just kind of take an upper tertile compared to the lower, what you end up seeing, and you can compare them while people are performing aspects of memory in the scanner. And again, we're seeing these same issues. So I didn't have negatives to be able to tell you whether there's kind of synergy or additional alterations. But what we do know is that, these things are extremely important, that the mental health and cognitive health, and I really don't even know anymore if they can be, we measure them separately, right? But from our own kind of clustering and machine learning analyses, what we do know is that you can identify people with any different combinations of factors. And so it's all comorbid. And the question's probably, what are these underlying dimensions that are perturbed underneath it that kind of lead to that picture? And these are all very important issues that I can tell you from NIMH's perspective, that's kind of where things are going. I know I can give a quick comment that, and I'm going to send this to the CFAR, Richard, but we're spearheading, Boansis and I, in conjunction with NIMH, biotypes of CNS complications in people with HIV. So moving away from the kind of definitions, right, of HIV-associated neurocognitive disorders, which many people may be familiar with, which, kind of stepping away from that. It's very siloed to just cognitive issues. But again, these mental health, anxiety issues, again, all go together, and really needing to focus on that. And so I could send you the information for anybody who's interested, because I think from a research angle, that's going to take us, I think, some places a little bit different clinically down the road. So, yes, there's problems. I think we can all agree there's problems. It hits the brain, but what can we do to help? What are we doing now to help? And I think that's always been kind of this big kind of issue, is that it's fine to do these imaging studies, the epi studies, to identify the problems. But then again, I'm not the MD, I'm not the practicing clinician. So how can I kind of help you? And this is where I know I need to reach out and connect with the implementation science folks. And I'm here to kind of tell you what we've been doing in clinic, but I'm also very open to listening to you guys and working together for how these things may get even integrated to a greater degree into clinical care of your patients, acknowledging the fact that you guys are extremely busy, right? So that is well known. And you can feel free to stop and ask me questions as well. I didn't know if you were leaning in to ask a question, Richard. Just, no? Okay. You're on mute.
I was leaning in because to emphasize how much I agree with you.
Okay, I like that. Okay, so let's start with mental health. And again, these are constructs that have been measured separately. And so let's think of the standard mental health assessments that are typically done, right? Oftentimes we give people questionnaires. It could be the PHQ-9, the Generalized Anxiety Disorder 7, right? It's no more than jumping hurdles. Every time you see your patient, you see the same questions, right? Have you been, sad? Have you lost interest or pleasure in things? Every time they come into clinic, they're asked the same questions. That is considered, to me, jumping high jumps, or not the high jumps, the hurdles. Same thing, time and time again. We've moved towards this kind of paradigm shift to mental health measurement, which is more in line with a high jump. So if you have a patient who's coming in that's, is depressed or has these issues, right? You're not going to start with this kind of softball, same questions again and again. You're going to start, or think if you're a high jumper. I am a novice, and if I was ready to jump the high jump, you probably have to put it like a foot off the ground, if that, for me. Now, if there's an Olympian who's going to jump it, are you going to start at a foot? Probably not. Who knows, 6 feet, right? So you're kind of titrating it. and trying to get at the issue with the absolute fewest number of questions possible. Okay, I'm not the mathematical genius behind this. This was work and kind of creating these tools came with Robert Gibbons, who actually used to be at the University of Illinois at Chicago while I was there, who's since moved to the University of Chicago, and developed these models to actually be applied to mental health, which is a lot more complicated than doing an SAT or something of that nature. And so what we've been doing in clinic is using computerized adaptive testing for mental health, so that participants or patients get different items based on their severity. We try to give them the smallest number of items for fixed precision. So the quickest way we can get at if there's a likelihood of major depression, PTSD, substance use disorder. And the available questions are actually selected from a huge item bank. So there's thousands of items in there. And what we are capable of doing is assessing a number of mental health conditions. Now, because we've been doing this in clinic, and it's more for research, right? Less for clinical care at the moment. We've been assessing everything, so that's going to take a bit more time. But the way you can see this is that if you're worried about depression, you might be screening folks in just a depression module and following them over time. And I'm sure there's other instruments out there as well. This is just the one that I have been using across all of our studies. And the nice thing about it is that if there's actually an issue, you get output immediately. If there's somebody that is very likely to have major depressive disorder, in real time, I know if they are potentially suicidal and they're at high risk, we can actually do something about it. And early on, when we had funding, and this is where Richard, we had teamed with Glenn Treisman in psychiatry, so that when patients were popping positive, they were never left alone. They were immediately linked, whether they had to talk to the person on site, the ER, or whatnot. And I think that's important because, I'm not sure if they all divulge to you, but sometimes you can sit and look at this. Oftentimes they may sit with these questionnaires or these kind of items for a long time. We can actually see if they sat on that question for, 5 minutes and then answered no, right? If you're sitting on these things, there's likely to be an issue. So we have to date, I think there's more now, but this is the data that I had pulled in clinic care, looking at the disorders that we pulled. So major depression, mania, so getting into bipolar a bit, generalized anxiety. We did again screen for suicidality, post-traumatic stress disorder, and substance use disorder. We had screened 339, a reasonable split between men and women. And you can see at least, overall, it's a little over a quarter, right? And these are, 27, 26% of any individual, within the clinic that we kind of threw out the net and cast is what we're seeing. And I think, we had 9 patients, or 3% reported suicidality. The mean of doing everything, of course, you can see, again, this is in a research study, so this does take time. If you're doing everything, we can actually screen for psychosis, social determinants of health, adult ADHD. But again, you could screen for one thing. But this is a way, in a computer way, where you're not having to score and being able to kind of put your finger on the pulse. The other thing that I did pool was actually the most common diagnoses. So of the patients that came up reporting, meeting criteria for issues, I was actually a little surprised by this, actually, and maybe, mania or thinking in bipolar, that's 15% just in and of itself. And you guys can comment to me. I would have thought it would have been, maybe depression alone, but you guys actually have a lot of kind of these more mania symptoms that are being reported by your patients. And then you can see not surprisingly, these kind of combinations, which is what I would have expected. And of course, it's going to start, the numbers are going to get lower and lower. But I just wanted to give you a picture of what is being reported. Okay, I'm going to skip that. Any questions on the mental health kind of screening that we've been doing?
I might have missed it, but in terms of how who's getting selected for screening in the data you just presented, was it just like a sequential thing, or how were patients?
Anybody that's, I mean, for us, it's anybody that's willing to, you know, consent, and whether we can capture them before, after their clinic visit. So again, everything we've been doing, while it's in the context of routine care, if you really want to start optimizing these things, we need to figure out how to best work into your workflow.
Right.
Right. So, and these are things that I've, you know, Richard and I have talked about, but, and I think that's why I selected this talk over some of my other options. I have a lot of other things that I could talk about, antiretrovirals in cognition, or a whole host of, you know, on the cognitive end of things in mental health. But you as the practicing clinician, how I can work with you to best facilitate patient care, knowing that I'm not the one seeing the patients. So how can my knowledge help the patients that you guys see? And how can I work with you? And I think that's, you know, really where it comes in. And while we've been doing the mental health, unfortunately, we've had to pay to do those things, which is not sustainable. Cognition, we've been able to do for free. And anything that I do with what I'm going to show you next is for free. So that becomes then something that might be something that is very real. That is a possibility.
Amita has very politely raised her hand.
Oh, sorry.
Just talk.
Go for it.
It really enjoying your presentation so far, with lots of sort of practical and important findings. So our patients spend a lot of time waiting and sitting in waiting rooms, or waiting in between. There's sort of both entry, exit, and I'm just wondering if there's a way for your tools that you're using either to be delivered via sort of iPads and sort of self-administered, or could be done by you know, our MOCs or others in the clinic and not require specialized training. So just interested in how long will some of these types of approaches to get an initial rapid screen take?
Yeah. So again, you know, we've been doing the CAT-MH, but we pay for it. Apparently, like your university there's been universities who've actually integrated that into their systems. At some locations, I think like North Shore, places in Chicago, and then it could be used anywhere, right? Like you can see how something like this can be important for even people going to the ER and figuring out how you triage, or people who do this and go on wait list. I mean, this can be used for many different things. This is 100%. It can be done on a phone, an iPad. Well, for the mental health stuff, the cognitive stuff needs to be done on an iPad. The question is whether the iPad would walk, right? But I can see somebody, like, I think of it as, you know, a patient goes into the waiting room prior to seeing the clinician. They get height, weight, blood pressure, and they do their basic stuff. Now we're doing in the context of research, so we have to consent and do all of those things. If this is not being done in research, why can't the nurse who's going in hand this over, and the patient does the cognitive assessments, which take 5 to 7 minutes? Now, if that's a reasonable like time that they wait in there, then that's something that could be done. And actually, what I will show you is that you can actually extract the PDF and actually upload this into Epic if you really want to, you know, track your patients over time. Like this was made to be something that, you know, how can we help patients? And it really started focused on HIV, since that's been my primary focus. But I think you'll see that it has utility way beyond HIV. And we've worked with the patients, as well as providers, research coordinators, to get the tool where it is right now. So it was very initially felt like an HIV tool. Like it's red, you know, we I'll show you the screenshots and some of the things that we've done, but we've made this where you can do a brief screen. You can actually do a full kind of neuropsych battery on this, or you can do something that's a little bit more custom based on what you're worried on. So we're getting this. This is like, yes, we're putting this in the MaxWise combined cohort study and other kind of bigger studies. The question is how can we work with clinicians to facilitate your patient care, right? Because if you're
like a great quality improvement project that could be done in the clinic if someone wants to,
right? You guys focus on every organ, but this is like something that could be focusing on the brain. And I do think if somebody comes up as impaired, even, what's driving the impairment, you might handle them differently. If they can't remember, they can't do things, I'm going to give them paper. If they're going to, how are you going to best work to get your patients to do what you need them to do? So, I mean, for me, cognition, and I'm on, I'm in the ACTG, I'm in all of these kind of cohort studies, and it's trying to get to the table that cognition is not a sub-study. Cognition, when you guys give medications, when you change medications, when they're prescribed multiple non-ART medications, all of these things can influence it. So how are you supposed to track something objectively if we're not integrating anything? And I can tell you medications with anticholinergic properties, our patients, I mean, we've seen that to take a hit. Polypharm, I mean, things that we know. A lot of the antiretrovirals, we put them on that, but it's also important to know what, in some folks, what may or may not cause some issues. So if you're not tracking it, and again, I'm not in the room, I'm not following the EPIC, I'm coming at you as the researcher, and that's why everything I do is partnered, because you are the doctors. So let me, because I like the questions. I would prefer to answer questions, and that's really, but I do want to show you the data and a little bit of the tool to just give you a feel. And, I have to give the screenshot for the paper because Richard knows how long, we collected the data in less than a year, and like 400 folks, right? Like, this was relatively easy to do. Publishing, I don't think neuropsychologists always love that you're, developing tools that doesn't entail, but think about the amount of effort, so maybe even prior to sending somebody for neuropsych or something of that nature, if you're screening, at least you have, it could be that, wait a second, they're screening positive, maybe I need to inquire a bit further, or something I can do, or do they really need to be kind of assessed further? So I'm very proud of this team-based effort. So
a couple questions from the chat. So one is, could patients do this on a phone app as well while waiting as another option in advance of the visit?
We're working on, actually, we do have apps, but what we've learned is that, because I actually have an IRB protocol to do, it's called the hand-in-hand app. Patients don't have iPhones. So before even the study got started, that kind of, we learned that very quickly. And so if we're gonna do anything via phone with patients, it's gotta be Android. And there's pluses and minuses to that Joan can answer. I'm not the tech person. I'm the conceptual person who works with the engineers.
And then a follow-up to that is from Brittany Davis, which is there an option for patients who are technology averse and who can't use tablets?
Absolutely. So you're going to see the data. We tested, you'll see of the 404, 70-some% were over the age of 50, 30% were over 60. These are old folks. These are people who, no, they're not tech savvy, but it may take them a little bit longer to get through it, but they are competent to do it. And we've done a lot of like question and answers to get their feel for what they like, what they don't like. And you have to remember that their performance is normed to somebody that is age, sex, race, and education matched. So if you were taking out the HIV, where should they be performing relative to somebody with HIV? And that's how you get that kind of Z or T score to figure out where they sit.
And then the last question before we move on is would this be available from Kathleen? Is this available in other languages and adapted for patients with limited English proficiency?
Okay, so we're working on the Spanish translations. I can also tell you that I have an R01 in Uganda, and we're doing some of these tasks abroad. So we've translated it into Luganda. We're not doing the full thing, but this was made to have, in many ways, low literacy. So you'll see, like, typically when you do a trail making A, and let me just show you because, or I don't actually have the B, but, it's, connecting dots, with your finger. And typically with a trail making test B, it's usually letters and numbers. We've removed the letters and we use shapes. So that kind of takes that away. For Stroop, when you're pushing the buttons, initially we started with the letters, like red, and now we've got the colored blocks. We've integrated a lot of what your patients are telling us. I've gone on community advisory board, national CABs, whether it's mostly in the MWCCS, and I've learned a lot. Like when I've spoken to male men, they've said, well, have you thought about color blindness? Because it's a real problem in men. And I said, no, like I didn't know that. And it wasn't something, so we've integrated, do you have sight issues and can you see this color? So we are trying to work with the patients to also, and you guys. So of course, it's like an app that can get updated and altered. I've met with numerous neuropsychologists. What do they think? And so we want this to be as user-friendly as possible. You can get an account, you can go in, you can track how people are doing. And it's as simple as starting with the subject ID and PIN code, which you can keep in a record. You can select whether they do BRACE, which is the screener. You could do BRACE Plus, which is a full assessment, or you can do a custom configuration, which is, I'm going to select some tests, right? You can just kind of click the boxes of what you're interested in and go from there. So this is what I was saying about issues seeing. And we ask questions about education, age, all of those things. They're not kept in the iPad. They're on a HIPAA compliant server. Date of birth isn't kept. It's used to generate age, so we can generate the norm, so you can have a T-score to know whether they're impaired or not. So we ask within this, do they have problems seeing colors? They ask what color it is. And then very similar to what a neuropsychologist would do, there's audio and video. I can't show you that right now. So there's an audio and a video that tells you instructions, which is exactly what a neuropsychologist does. They show, you do a practice, like they're showing you, then you do a practice. And then, oh, I should have told you to stop. I do want to share the data. Thank you. So the 404 people that we assessed, you can see what the mean age is. And I had mentioned the proportions here. We had a pretty nice sample of males and females. Again, I do a lot of work in women. So it's very, I try to make sure that we're always enriched for that, because I know it's not exactly equal in clinic. And you can see, not surprising, the art regimens they're taking. Hopefully this is, what you expect within your patients to see with medications, and kind of the demographics of your folks. Again, this was for research purposes, but we extracted from the ICD-10 codes. So we wanted to understand what's in the medical records of the folks that we're seeing. And so you can see these are folks, again, we just threw out the net. So there's a lot of comorbidities. This isn't surprising to any of you, probably, right? This is, I think, very common. Cognitive assessments. Now, these were in older folks, and there's it's a little bit longer because it was in the context of research. If you're just doing the screener, it takes about 5 to 7 minutes. But with our older folks, it did, take about 11 to 12 minutes because they were just slower. The performance on this tool, which we called BRACE, it's brain baseline assessment of cognition and everyday function. We get really nice. This is just T-scores. So T-scores have a mean of 50 and a standard deviation of 10, right? So this is, a half a standard deviation is this gray dotted line. 40 and below is a standard deviation. So you can see kind of the proportion of people who are falling below for each of the individual tests. And then if you kind of create a global score, which is like taking the average of these things and looking at a 1 standard deviation or a 1 point standard deviation cutoff, looking at percent impairment on each of the tests or on global measure. I mean, it's 25% with what we threw out the net in your clinic so far. There's much lower percentages at the more severe forms, which is, I think, is what is kind of expected. Again, with antiretrovirals, we don't see a ton of HIV-associated dementia, right? I think we see a lot of cognitive impairment, whether it's due to HIV or these other factors, or whether HIV exacerbates all of these other factors is something, there's a lot of questions out there, but this is what we see. Probably asking, or I know I wanted to know, how, from a reliability and validity standpoint in our research, and these are going to be smaller numbers coming from my other studies, looking at retest reliability, right? How well does performance at one time point correlate with another? And we do studies in our pharmacologic challenge where people are actually assessed every 4 weeks. We were not seeing practice effects, and in our smaller sample, which actually have a lot more data now, is 0.81, the correlation between, taking it initially and 30 days later. I think that's pretty darn good. If you look initial and almost a year later, it's 0.63, right? So as time progresses, there's likely to be things that are happening. So it's going to be, you're going to start to see a little bit more scatter. And then the question of validity is, how well does performance on the iPad tool relate to the gold standard neuropsych testing? So again, I was very fortunate to have a lot of people who had also completed, neuropsych tests, and across studies, we pulled 4 tests. So it was 4 and 4, and it's 0.62, which is pretty, good for a, standard to just this simple iPad tool. You can see the just the correlation matrix of here's trail A, B, Stroop color, and a visual spatial. Now, I'm not surprised by this. I'm not going to go through all the definitions, but we didn't have a visual spatial task in our neuropsych testing. But you could see here with our, you see with symbol digit modalities, trail A and B, you see the right correlations. That's good. And then I think what's important is that if you were to do the gold standard battery and you were to determine whether they had global impairment, whether they were normal or impaired, and then you had them do this iPad-based tool, very good that we see that the tool picks up on this difference, right? So that if you are impaired on a neuropsych battery, you're impaired, you're below 40 on this tool. I also we just did some basic logistic regressions because we had data to see what are the predictors. And I talked to Allison Agwu because I was on one of the working groups, the SWIGs from CFAR. This was one of the more interesting points. It was counterintuitive to, I know, Richard, Carrie, and I, but look at age. I would have thought that as you get older, right, you're more likely to be impaired, just, with age. Granted, these things are all corrected. It was not the case. And I went in under the hood and looked kind of by decade. Some of the most impaired people in your clinic are your younger folks. And we're not assessing them. So that is my kind of, and I've talked to Allison, how do we tap this kind of younger group? And you can see, so there wasn't a ton of things that came out from the medical record, but I think age and our younger folks, and these were folks that were, I think, closer to 30 or a bit younger, that starts wanting to push this into your adolescent clinics. And I know I'm working and I'm a mentor of Ethel Weld, who amazingly got her K award. So extremely proud of her, but she's going to be integrating some of these assessments in her studies, looking at, which are in younger folks. But again, how do we go big? This was our effort of starting small, right? I went to Richard and said, can we do this? And he said, right, Richard, go ahead. And I think this grew a lot quicker than we thought. I think this was going to be slow, and I think it's gone pretty well. So I'm going to end there to give you guys ability to ask, some questions. But, Joel Fuchs, who now is amazingly in graduate school, got to do 2 PhD programs and is now at University of Maryland, who is so integral in getting this off the ground and staying on top of this. Meghna, who is now kind of taking that torch and moving it forward, is doing an amazing job. Lois was here. Ned unfortunately passed away. Richard, Carey, and of course, CFAR funding, other aspects, Richard's grants, his NIDA focus grants. We couldn't do this without all of that. The question is, how do we do this without funding? Or how does that, and that's a very different question. So with that, I'm going to stop talking because I'm a talker. So thank you for listening to me.
Thank you so much, Leah. If folks have questions, you can either shout them out or put them in the chat. I'm going to read one that just came from the chat. So it's from Maya Kresge. She's wondering if you had a chance to compare the diagnostic and prognostic utility of the BRACE digital scale to the MoCA or mini mental or other standard quick in-office measurements of disease progression rather than in-depth neuropsychological testing. And also curious if the poor performance on the BRACE correlated with symptomatic impairment that was noticeable to the patient or the people around the patient.
I could easily get you an answer to the question on the subjective complaints. I think, actually, I have it in the paper, the proportion of people who are impaired who also self-reported. I know in our full sample, it was like, there's an over-reporting of issues. I think it was, memory serves, like 67%, because we give a PHQ-2 and the self-reported, it's like the PALFI. We have the 5 items that Tom Marcotte, what are the fewest items that you need to do to get at the full assessment. And we have very high rates of self-reported complaints, but it's likely to be an over-reporting. So that's a really good question. I missed the first part. My working memory is not so good.
So if you've had a chance to compare the diagnostic and prognostic utility of the BRACE to the MoCA or other standard in-office assessments?
Not to those. I think others may have. I can ask Joan, because this started at UCSD and then we really kind of hit the ground running and pushed it into like routine clinic care. The MoCA and all of those tools, if you're severely impaired, those tools are very good at picking up severe impairment. What those tools, and there's been articles written by Benedetta Melanini, Victor Valcour. I know actually Meghna, Carey and I putting together a paper, Meghna's spearheading that. The problem is capturing these more mild forms. And that's where we've always kind of had this issue. And as these folks, whether they're younger and they're showing it or getting older and showing it, right? Cognitive impairment, whether it's due to HIV or something else, is going to become a greater burden. We need to be able to pick up these more subtleties because they may be indicators of what's to come. And you're never going to get that with those other tools, unfortunately. The other thing to mention is that this is meant to be self-administered as long as the iPad isn't going to walk. There are other tools, many of you may have heard of, like NIH Toolbox. A lot of people have tried to go after this route. NIH Toolbox is a sister. You need to have somebody who's actually knows what they're doing to administer it. This is meant to be very little burden, little training. Rubin Robbins developed a tool, but it's more computer assisted. So there's always going to be pluses and minuses to everything, but I could see something being like a 2-stage, right? If you come up and you're impaired on this tool, maybe I say, go, if the participant has time, go do the full battery, or I'm going to embrace it a bit. If they're impaired, they need to actually see somebody. So you can do it in a kind of a step care like model or something of that nature, but this is free. This is something we can actually really work with.
So we should consider it more of an initial screening tool then, and then still
Yeah.
follow neurocognitive testing.
Meant to be, yes. So nothing's meant, it's a screening tool just like anything else, because the gold standard is neuropsychologist, right? And nothing is going to replace them, but their wait lists are very long. And so if you do have 25% and you are trying, or 100 patients come in and you're trying to really figure out who needs to go for those evaluations, you can also use this as a triage. Like, okay, these are the patients I may need to push forward. I could see it being, I can see a lot of utility. But again, we started with HIV.
This is Richard. I was, I don't know if I was surprised, but I was impressed by the high proportion of people in our practice, 25%, that appear to have cognitive impairment, at least based on this tool, making me think more and more about how we can clinically integrate this, where it isn't just a research tool. And to your question, Natasha, and Leah answered this, these people weren't selected at all in any way. I mean, it wasn't exactly sequential, but it wasn't because they were selected because something seemed to be wrong with them. And that wasn't the case at all. And whether it's this or whether the mental health examination, mental health assessment, which is also 25% or more, thinking about ways to integrate this more clinically, I personally think is awfully important to do in the future. Joyce, I know you're on the call. I don't think Yuka was able to make it today. And I know, Amita, you earlier on asked a question about how to do this. And I think, Leah, it sounds like you'd be very willing to work with anyone to figure out how to.
Really, because out of all of the grants that I have that are focused on mechanisms or, this is, I really feel like I was very fortunate to meet Joan, but I actually feel like this is something that can actually make a difference from a public health perspective. And and of all of the stuff I've worked on, it's really cool, right? To look at neuroinflammation, all these things. But this is something that we can, actually put the pedal to the metal, but it won't be just me. I need to figure out how does this go into a workflow. And the reason, honestly, why it took so long to get published, because, neuropsychologists are reviewing it and they're like, well, you're just doing it's a convenient sample and you're not excluding for this and that. And like, that wasn't the purpose. The purpose was, is this something feasible? Because are you going to exclude? You don't care. You just, doing an annual 5 to 7 minute assessment, to me, again, I'm not the clinician, seems reasonable. I would, as a patient, would do that in any of my, routine healthcare visits. So again, I may not be the typical person, but I think of, they screen mothers for perinatal depression, right? You postpartum depression, like how does this get integrated? How can you eventually, again, we're so far from it, where it is something billable, where it becomes part of routine clinic care. So I feel like Dick, Richard, like this is where Allison Agu, like this is where working groups, clinical cores, I think this is something that really can get tackled and with you guys. And it really could be as simple as you tell me, like, I want to integrate this into my clinic and we figure a way to do it. Because I know when Lois was here, she purchased a ton of iPads. So it could be, and IT set it up that you can do this. We probably have to update it because I don't think those are the ones that are used, but that's how we can do it. It doesn't have to be for research. We can get you going, right? I'm happy to go one by one. It's a much slower approach, but how else are we, I don't know how else to go about this, but it's almost like Meghana, it's like, how do you walk through clinical care and figure out the flow, the workflow, where it could be integrated and things of that nature? How does it get in Epic? How do we, where it actually becomes useful to you? Is this something that would be important to you? And it's okay if you said no, but I mean, I'm really looking to the clinicians to put on your, so I see faces because I can only read eyes and smiles or no smiles. You can give me stern looks, but I really want to hear from you.
Anna Claire, you raised your hand. Anna Claire, did you have a question?
Man stepped away.
Yeah. Hi, Joyce.
Hi. Thank you so much, Leah. This is really, really important work. Nice job. I unfortunately had to take a call during part of your session. So sorry, but what would be an intervention that we would do? So we do a screening and then, they score something that's concerning. What would be the next step?
Well, I guess the first question as the practicing clinician is there anything that I've recently switched their medications? Are they on additional non-ART medication? Like, is there anything that's happened, to kind of figure out if there's some circumstance, right? Because that's something that you could do to track, if I put somebody on an integrase inhibitor, are things, at least it's not perturbing that function, right? It's important to know even if it doesn't shift. Intervention wise, that's the biggest, which is why I do mechanistic studies and treatment studies, is there is nothing to date. There's no treatments to stop, slow, or reverse these problems. And it's a really big problem that, and that's why the mechanistic and pathogenesis and all of those grants get funded, because at the end of the day, we need to figure out what's driving it. So I don't have that answer, but, exercise, good for cognitive, like there's some basic things. I find that a lot of the patients, at least that come into our research studies across numerous, are really sedentary. But I would think this would be important for even folks going on PrEP. Like, are there, I just see a lot of utility all around. But I think this is kind of going to be something like where it's like training wheels, right? We're going to figure it out, but I need to work with you guys. And Joyce, I'm happy to meet with you separately. Again, you guys are the bosses. I'm coming to you and just trying to figure out, I'm not an implementation science researcher. So I've not dealt with those issues, but an implementation science, I'd be happy to work with them to write a grant. That's where it starts to get outside of my wheelhouse.
Yeah, and I think, sort of practically speaking, I can speak personally as a clinician, I like to do screening. And then once I do the screening, it's indicating something that then gives me a path for action. So I think that would be something to sort of figure out, have this information now, how can we use that to provide better care for the patient? But yeah, I'd be happy to talk to you. Like, maybe we could pilot some things for our older patients. We do already an annual wellness visit, and that can be time consuming, but it feels like a natural place, to do something like that. But yeah, I think we could explore how to integrate it. But then once we have it, it's sort of like, what kind of guidance would we give providers and patients, it can be scary, right? Like if you have this information, you have cognitive deficits, especially for younger people. Like, what does this mean? And you know,
You can also have a really bad night's sleep. We know sleep influences cognition or distractibility, you know, if they were doing it in an area. So if there's something like that, you're going to know, yep, it's probably sleep. You were sleep deprived the night before, right? So we just have to be able to pick. I unfortunately have to meet with Justin, so I do have to run. But anybody who wants to meet, honestly, please email me. This is like